This is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Stand next to your fire. Yeah, let me stand, baby. Let me stand. Oh, let me stand. Oh, move over. And let Jimmy take over. Yeah, you know what I'm talking about. Yeah, get on with it, baby.
Good morning, everybody. That was the immortal Jimi Hendrix, and I'm Dr. Minarsik, and it's Tuesday. It's January 31st, the last day of January 2012. We're in Chicago. It's about 9 o'clock, and we have very good weather last couple of days. It's been almost 50 here, at least in the afternoon, so let's hope it holds out. This is our 40th 2-hour session in global medical school pathology, and I guess because I was not inspired with anything to say, it's we could get right into it and do the test questions. And the first test question is, can everybody hear me all right? Great. Now the second test question is, what do you see on my screen? Yes, lovely girl is the correct answer. Thank you. I guess we're ready to go, and you know, I always find something to say before I get wound up. I really don't have anything to say. I think I could remind you at this point, which is a good time, that all of you who had been at the majority of the Pathology 1 sessions and sent me an email and said, yeah, I was there. Well, you all got your certificates. I'm very proud of that. Now, let me tell you what we do for part 2, which is the entire course. We do something bigger and better. Last year, for those people who had attended the majority of the sessions for the entire year, I give them a little project. I said, you go to Rock Lab. There's about 500 cases there. And you answer all the questions associated with those cases, and a lot of them were identification of structures and clinical questions. And I also said, you know, you don't have to do it alone. You could find buddies, you could find friends, you could Google, you could wiki, you could cheat, you could do whatever you want. But when you're done doing that and you have emailed me the large file showing that you had worked at Rock Lab, then we'll schedule about a 5 or 10 or 15 minute chat on Skype, and we will give you more than a certificate. We will give you a nice reference should you need one. But remember, this involves some work, and not everybody is going to do it. A few people did it last year. I imagine there'll be a couple doing it this year as well. So those are the rules. We don't give exams here. We don't give grades. We just give assignments to work, and then when you are done with that work and you talk to me about it for a few minutes, then we give you something that is the culmination of all of those crazy concepts like grades and exams and A's and B's. We give you a nice reference to show that you've done the work. Okay, that's basically my only announcement. Today we will be finishing the chapter on vascular diseases. I thought we could do it in 2 sessions or 4 hours because that's a lot of time. Apparently we didn't. I'm probably going a little bit slower these days or into more detail, I don't know, but there's still a little bit left to talk about. Mostly vascular tumors, which we should whip off pretty quickly. And then we have a good-sized vascular histopathology lab. There's at least 13 or 14 cases here, and I carefully selected them and I weeded out the ones that I didn't think were too appropriate. So after our first exercise, I don't think it'll take an hour, probably less, of finishing the chapter. Then we'll do a medium-sized lab, and if there's time left over, which there might be, we will then take a nice big inhalation and pat ourselves on the back and go into another extremely huge chapter on heart disease. So that's basically the agenda for today. You know, I've been announcing these on Facebook as well, so if you join the global pathology course, you'll be able to understand what you're going to be getting into every day. I think a good place to start here is the one that says Chapter 11. And we did a lot of things on blood vessels. I feel like we did a pretty good job. Generally speaking, blood vessels is not the most exciting thing to talk about, but in my opinion, it's one of the most logical. Heart is also logical, but heart is also graphic and interesting and clinical as well. So if you remember, we were about 2/3 of the way down. We talked about lymphangitis, and we showed you the orange peel. We mentioned something about chyle. And now, technically, we will be covering this part now, vascular tumors. It's the only topic left under vascular diseases. And you know, pathologists just love to talk about tumors. If you ask them to talk about vascular diseases, they'll talk about vascular tumors for 2 hours and then the rest of the diseases for 2 minutes. But you're not interested in that. What you're interested in is the scope of vascular diseases, and we will have to say something about tumors of blood vessels at the end. Okay, there's a lot of them. They go by a wide variety of names, and there's probably too many for me to even remember, but let's talk about the general principles. Vascular tumors are tumors of connective tissue. They're tumors of endothelial cells. They're generally mesenchymal or connective tissue tumors. Because all tumors are generally classified as benign or malignant, or sometimes intermediate in between, that's pretty much the same way we classify vascular tumors as well. So a benign vascular tumor, not only does it never metastasize, but in many cases I think there's an argument that a lot of them aren't even really true neoplasms. They are not true clonal neoplasms, but they're just overgrowths of normal tissues. You know, like for example, birthmarks in children. They basically are tissues that are still growing and they eventually mature or resolve. Now, the intermediate class of vascular tumors are tumors that may be locally invasive, possibly, but they very rarely metastasize. When an intermediate tumor metastasizes, you know, it makes a big topic, and all the pathologists talk about it for years. Of course, the truly malignant vascular tumors, going by a variety of names, Not only do they frequently or usually metastasize, but they often metastasize early in their growth phase as well, perhaps even before they've achieved a significant size grossly. And remember, these are tumors of connective tissue. So we said that malignant tumors of connective tissue have the name sarcoma. Okay, and they behave like any other sarcoma. They metastasize through blood vessels early on in the phase rather than lymphatics. And so often the very first clinical sign you have of a malignant vascular tumor is like you would usually have the first sign of any sarcoma, and that's metastasis to the lungs, because with vascular spread, the only place it can go to is lung. So those are the three general categories. The generic name for a malignant vascular tumor would be angiosarcoma, but I want to warn you, there's a couple of malignant metastasizing vascular tumors that would fool you because they don't have the word sarcoma in their name. And of course, the general generic word for a benign tumor would be something like a angioma or a hemangioma. But there are many, many, many other little names, some of which are proper nouns, some of which are named after people, and we're not going to get into that mess today. So here's something which I hope is extremely logical as well, and it pretty much conforms and complements to everything that we ever said about tumors in general, is that if you look at the spectrum of vascular tumors all the way from benign all the way to malignant, let's take three features, not only histologic features but behavioral features of that tumor. The benign tumors, examining them, might have a rare mitosis, because remember, even granulation tissue, even neogenesis, even organizing inflammatory blood vessels, you'll see mitoses every now and then, because if new blood vessels grow into an area, they have to divide, don't they? But you don't see them too often. Now, if it's a neoplasm, and it tends to be on the malignant side, you're more likely to find more mitotic figures per high-power field. And this is true with just about all of the connective tissue tumors in general. Not so much always the epithelial tumors, the carcinomas, but especially the sarcomas. The more malignant they are, the more mitoses they have. It's a very important feature. Another thing also goes without saying, I hope, is the atypicality of cells. A benign blood vessel tumor would not have very many atypical cells. They would all, the nuclei of the cells would all generally look about the same size and same shape and same intensity of taking up the hematoxylin dye. But the more malignant it is, the more atypical the cells are, which means the more bigger they are, the more irregular they are, the more dark they may be. And these are all characterized by the phrases hyperchromasia, pleomorphism. And of course, the third one is a behavioral feature rather than a histologic feature. A benign tumor, vascular or not, by anybody's definition, doesn't metastasize. That's one of the strongest definitions of a benign tumor. Even though in a couple of cases, you know, you'll hear pathologists talking about supposedly benign situations that metastasize. We'll pretend like that doesn't exist. Malignant tumor, and the more malignant it is, the more frequently it metastasizes. And remember, we've said this before, the sarcomas, the connective tissue tumors, which all the vascular tumors are in the family of, metastasize usually through blood vessels, as opposed to carcinomas, which frequently metastasize through lymphatics. So these are all things which I think were logical, but I put it in there anyway, and it's in Robin, so it's worth repeating. Let's take the garden variety standard benign blood vessel tumor. Let's call it a hemangioma. That's the most common name for it. Often the word hemangioma is used as a generalized generic term for any benign blood vessel tumor, and sometimes the adjective capillary is put before the word hemangioma, and sometimes the word cavernous is put before the word hemangioma. And they're both benign. And in a capillary hemangioma, which you might expect, would be a tumor of blood vessels in which the vascular spaces within the tumor are very, very small. They're hardly larger than actual capillaries. Sometimes you could barely see them spaces, even microscopically. And very often, these wind up as being birthmarks. So when you hear of a baby that has a red birthmark, most likely it's going to be some type of hemangioma. And if it's a capillary hemangioma, that birthmark is going to be characterized by very, very small slit-like spaces. And the caveat is, when the blood vessels are very small, often they regress. And sometimes the biggest, hugest, reddest, yuckiest looking, gigantic birthmarks will completely disappear within a year or two of age. And if they do, and you had looked at that, most likely it would have been a hemangioma of the capillary variety, in which the small vascular spaces were barely larger than capillaries. Now, the cavernous, which sounds like a big cavern, those are benign blood vessel tumors. And when you look at them, there's large vascular spaces. You know, you could probably, fit a small football team inside of them. And they are also called the adult type of hemangioma. And generally speaking, if they present as a birthmark, they usually do not regress. So what do you remember? The smaller the benign blood vessel tumor is, the more likely it is to regress. Here is a hemangioma of the tongue. Here are the blood vessels that it's composed of. Now I know you're saying, gee, are these little spaces all blood vessels? They're so small, I'm not sure if they are. Yes, they are, and sometimes you'll see blood cells inside of them. And if you look carefully, you'll see along the lumen, you'll see little flat nuclei like there, and 3 of them over here, and a couple of them over here. These are the actual endothelial cells. So, endothelial cells, if they didn't proliferate, it wouldn't be a vascular tumor. Of course, yes, you can have some connective tissue and fibroblasts in between them. So there's a capillary hemangioma. If this was in a kid, the doctor would probably tell the parents, don't worry, it'll go away. We don't have to do massive surgery to this baby. Now here's a hemangioma of the adult type. It's called cavernous. And remember, these could be anywhere. They don't just have to be in mouth or upper respiratory tract. They could be in the liver. They could be anywhere. Anywhere where there is blood vessels, you could have a blood vessel tumor. You notice how large these spaces are? You notice how there's a lot of blood inside of them? And look, you can see a nice row of maybe 20 or 30 or maybe 40 endothelial cells lining these blood vessels. And here's what it may look like. And these are not likely to regress. Now, clinically, when you examine patients that have hemangiomas, one of the things that you'll learn very quickly is the concept of blanching. In other words, if you see a red tumor, or actually any tumor that's palpable or visible, you may be tempted to stick your finger on that thing and see if it turns white. So, here's the questions. If it's a tumor of extremely small blood vessels, and some of them are so small you don't even see blood cells inside of them, is it just as likely to blanch as something that has wide open large spaces? No. So the larger the space, the more blanchable it is, the more it'll turn white for a few seconds after you press your finger on it. Now, I'm glad somebody asked a question about are AVMs type of benign tumors. It's a fine line of distinction. Both of them are mass-like proliferations of blood vessels. By etiology, we said that the AVMs, which we have already talked about, are generally malformations. They're congenital in origin, whereas the hemangiomas are generally neoplastic. But let me tell you, I think that a lot of the so-called blood vessel tumors which regress could very easily just be temporary malformations which eventually mature. Let's look at one of the most common types of benign blood vessel tumors, and in this case they're usually in the upper respiratory tract, in the oral cavity especially. They're called pyogenic granulomas. Well, it's the common term that's always used. The problem is both of them are wrong, because it's not really pyogenic. You don't normally see a collection of pus in them, and they're not granulomas either. Nevertheless, the most common type of benign blood vessel tumor, I guess you could call it a hemangioma, but they're called pyogenic granulomas, are in the mouth, upper respiratory tract. They usually regress. And you want to make things even worse? If I was to show the last 10 pathologists that won Nobel Prizes a histologic picture of a pyogenic granuloma, and then I was to show them a picture of absolutely normal granulation tissue, or we call organizing or neovascularization following an inflammatory process, they probably wouldn't be able to tell the difference. That's why, you know, when you have features like this, you often ask yourself, is this really a tumor? And that helps to answer the question about, could an AVM be considered a benign vascular tumor? And in all probability, if it regresses, if it's not monoclonal, I would say, yeah, it would not be wrong to call it a benign tumor, especially if the AVM has a tumor-like effect, like it's pressing on the midbrain or something like that. Okay, here's a pyogenic granuloma. Maybe you've had them, maybe you've seen them. It happens to be on the gum, it could be on the tongue, it could be on the buccal or oral mucosa. It looks like just a benign nodule. You know, if you've seen healthy granulation tissue grossly following surgery, it might look a lot like that. It's very vascular, but it's very clean. There's no pus on here. It's not pyogenic. And when you look at it microscopically, there's no granulomas, there's no giant cells. It just looks like normal granulation tissue. So that's a classical appearance of the double misnomer pyogenic granuloma. Now, you know, it seems like we've neglected lymph vessels. We said a little bit about chyle and lymph obstruction, but we haven't really said anything about the concept of a lymphangioma. Well, by its name, it's benign, isn't it? Because it has lymphangioma after it. If it had lymphangiosarcoma, you'd know it'd be malignant. They're generally very, very small, couple millimeters. They're generally also in the head and neck region, usually in small kids. Okay? They're rare. You've probably never seen one. You know, I've seen a couple, but, you know, I've seen a lot of things. When these lymphangiomas get very, very large, you know, not only more than a couple millimeters, but often the size of a head, you might think there's a double head, they, by convention, take on the term cystic hygroma. Now, even though hygro is the root word for water, you would imagine that they're big water-filled cysts, and they are. And they're lined by endothelium as well. Now, I know what you're thinking right now, so let's get it off of our chests. You're probably thinking, well, you know, if a lymphangioma is a benign proliferation of endothelial-lined cystic structures, and a hemangioma is a benign proliferation of endothelial-lined structures, how do I know it's really lymph, or how do I know it's really... Well, the answer to that is a good question, because I don't really know either, but I would say if you take the whole profile of a lymphangioma, you realize they're in the upper head and neck region. We talked about them being in patients with Turner syndrome, and if you ever see a baby that's like this, and I've seen a few, sometimes they've been stillborns, you see a large cyst-like proliferation in the neck, that's a hemangioma. You know, it can't be anything else. Another thing that might help answer your question about no matter how large or how small a lymphangioma is, if you were really wondering from the pathologic point of view whether those endothelial line spaces were of blood vessel origin versus lymph origin, let me ask you a question. If all of those endothelial line spaces had nothing but water or fluid inside of them and no blood cells, would you be more likely to call it a lymphangioma or a hemangioma? Of course, lymphangioma. On the other hand, if those large endothelial line spaces were loaded with blood and blood cells, you'd have a hard time calling that a lymphangioma, wouldn't it? Okay, let's go into another extremely common type of benign vascular tumor. It has the name glomus tumor. So another name is a glomangioma. But remember, these are all in the family of benign hemangioma type tumors. And once you put in the GL and you say glomus or glomangioma, you're almost always referring to something that's going to be occurring under a fingernail or a toenail. They're very painful because of that location, because of the extreme abundance of sensory and nerve and pain fibers, and they're very small. If it's going to fit under a nail, you know it has to be under a centimeter. So this is a glomus tumor. It's a benign vascular tumor. It's under the thumb in this case. I guess if you peel back the nail, these can be removed. The pain is gone. They're very common. I don't know if you've ever known somebody that had one. But remember, when you say glomus, you're almost always referring to a nail. And once again, here's the histology. I think you would agree that in this case, we have skin. And here we either have extremely thick keratinized later stratum corneum, or maybe it's even part of the nail. It's very hard to figure from this view. Now, you can see the epidermis, you can see the dermis, you can see general blood vessels in the dermis. But then you see this more dense, sort of well-defined nodular structure here. And if you look closely, some of them have slit-like spaces. And here's a higher power view of the thing here on the right. And take a look. Every single one of these irregular slit-like spaces is lined by an endothelial cell. So if you were to put your pointer on that cell or that nucleus or that one 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 or that one, you could say definitely these are endothelial cells. Now, could some of these cells between the slit-like spaces also be tumorous endothelial cells? And of course the answer is yes. But they could also be fibroblasts, couldn't they? So you wouldn't know for sure. But once you see, like in the kidney, when you see a glomerulus and you see capillaries within the glomerulus, and you see a little nucleus right at the edge of a blood cell within a small capillary, you know those are endothelial cells. Now, let's say you're in an area of the tumor like this, rather than here where you could see really nice, not only vascular spaces, but endothelial cells. You don't need to be a rocket scientist or a special stain to know that these are endothelial cells. But if you're in a solid part of the tumor like here, you would say, well, I think it's a vascular tumor and there's some endothelial spaces out towards the edge, but it's pretty solid here. I don't know if these are endothelial cells or not. So that's the problem. And I'm going to pose this to you. I'm going to see if you remember something. Do you remember which of the coagulation factors of the blood is made by endothelial cells? Anybody remember that? Aha, nobody remembers it. Well, yeah. Von Willebrand, yeah, but take a look at the bottom of the PowerPoint here for the answer. Factor VIII is made by endothelial cells. So if you were in a solid part of this tumor and you didn't really know whether it was a tumor of endothelial cells, but it looked like it might be, and you wanted to make sure if a lot of these cells were endothelial cells, what do you think you would do a stain for? You would do a stain for a specific anti-factor VIII antibody. So if the tumor cells in a solid area are very rich in factor VIII on your immunohistochemistry, then you would know that this is a tumor of blood vessels, even if you can't see the large open spaces. So that's a common stain that's done that identifies vascular tumors, even when you don't see many clear-cut endothelial cells surrounding blood vessels. It wouldn't be fair if I didn't throw in a few other little benign tumors, and some of them are not just tumors, they're often just descriptions. For example, the term telangiectasis or telangiectasia. That generally refers to dilatation of blood vessels, okay? It doesn't necessarily mean a tumor, but it's not the type of dilatation that you see in the early stage of acute inflammation. These could be things that just remain. Another thing to remember is that one of the most common types of blood vessel tumors in newborns is the port wine stain, and it's also called a nevus flammeus. I don't know why, I don't know the derivation of this, because it's not really a nevus per se. It's not really a tumor of nevus cells or melanocytes. It's more of a tumor of blood vessels. And it can look very, very red and regional. I know you've seen babies with this big red things. Those are very likely to regress with age. So the doctors tell the mother, oh, let's wait for a while, it'll probably go away. And usually they do. And remember, patients that have cirrhosis, in which there is a physiologic preponderance of estrogens over androgens, and women that are pregnant, where they also have an overabundance of estrogenic hormones, very often get these little they call them spider hemangiomas. We always call them spider hemangiomas. Here it's being called a spider telangiectasia, and what they are is little star-shaped expansions of blood vessels on the skin. That's why they're called spiders. And I guess you could call that a tumor, or at least from the very loosest sense of the word, and those are considered benign expansions of endothelial blood vessels as well. We may get into this later, but there is a very much discussed hereditary disease called Osler-Weber-Rondeau. We're not going to discuss all the details, but another name for it is hereditary hemorrhagic telangiectasia. So if somebody ever brings up this disease, like in a board question or in a grand rounds, that you're almost certainly going to be seeing pictures of blood vessels very similar to the spider that look expanded, and that's why it's given the name telangiectasia as well. Now, you know that HIV patients not only get malignancies of blood vessel called Kaposi sarcoma, even though they're low-grade malignancies and usually don't metastasize. They also get a bacterial benign blood vessel tumor called bacillary angiomatosis. And the reason why it's called bacillary is because we know the exact bacteria that cause it. It looks like this. Here's a gram stain, and it's in the Bartonella species. So this is a AIDS patient with a well-circumscribed sort of benign tumor, and it's very well localized. And when you look at it offhand, you could see maybe some blood vessel spaces. You might want to do a factor 8 just to make sure it's a tumor of blood vessels rather than something else. And certainly if you culture this or do a good high power bacterial stain, it will show up with Bartonella. So this is some more generalized, some more relatively common terms used for benign tumors. I wanted to warn you that there are many more, especially in dermatology. There are probably, 50 or 60 other weird names of vascular expansions, benign vascular tumors, given a wide variety of names. Some of them are named after people, which I don't think it would be appropriate to go here. Remember, this is not a pathology conference. This is a medical school pathology basic learning session. Okay, let's go into the borderline vascular neoplasms now. Everything we said up until now was intermediate. Let's go into the borderline neoplasms. And there's two big ones. One of them is KS. You all know what that is. Kaposi sarcoma. Some purists call it Kaposi because I think that the doctor who it's named after pronounced his name that way, but everybody calls it Kaposi or Kaposi sarcoma. It is a true malignancy, but remember, it's a low-grade malignancy. So even though you'll hear that the AIDS patients have these sarcomas of blood vessels, they're really borderline. You know, they're not going to kill the patient. They don't metastasize widely or early or very much. And even before the AIDS epidemic, we saw them in non-HIV patients. They were very, very rare. Sometimes we would see them in Africa, often in sub-Saharan Africa, in the same general area where, you know, AIDS is most rampant right now. Before AIDS was discovered or invented or whatever, we had some patients would be described with it. Sometimes they were seen in immunosuppressed patients that were HIV negative. So immune suppression seems to be the big feature. And in the immune suppression, whether it's transplant-associated and immunosuppressants or HIV, for some reason there's a little virus, and it's not the AIDS virus, it's in the herpes family. You know, it's called HHV8, herpes virus 8, which causes KS. Okay, so that's the cause of Kaposi sarcoma. And the ironic thing is, like everything else in HIV, it's not actually directly caused by the HIV virus, but the HIV virus weakens the immune system, so a regular herpes virus, or KSHV is another name for it, Kaposi sarcoma herpes virus, is the actual cause of it. So that's what causes Kaposi's. Now, the dermatologists and the pathologists, the dermatopathologists, would like to caution you that before you actually get these nodules of hemorrhagic, low-grade malignant blood vessel tumors, the skin goes through a phase of what they call patch, and then plaque, and then finally the end stage is when you see these red nodules. But before you see these red nodules, and here they're almost all red, but if you look in some of the areas, like perhaps over there, it's not really a nodule because it's not elevated. It might just be slightly thickened, what we call a plaque. Or it could be not thickened at all. It could just be normal surface. You know, you couldn't feel it if you were blind. And that's called the patch. So it's a progression of a disease that goes from a flat stage to a slightly thickened stage all the way into those hemorrhagic nodules. Now, I put a little asterisk after this second common low-grade or borderline malignancy called hemangioendothelioma. And the reason why I put an asterisk after it is because when you just look at the word, well, you see the hemangio, so you know it has to do with blood vessels, and you see the endothelio, so you know it has to do with some type of endothelial tumor. When you look at it, you would think it's benign just from its name, because the word sarc isn't in it. Well, it's still considered a low-grade or a borderline malignancy, and let me tell you, it's a very, very heterogeneous group of neoplasms. But we're not going to see a picture of it because it's a heterogeneous group, but what I wanted to point out is when you hear the term, don't think it's benign just because the name sounds benign. Okay, we've already seen this 2 or 3 times. This is Kaposi's. This patient presenting with red nodules on the skin, in the legs, anywhere actually. You can even see them in internal organs such as lungs. Sometimes they can even metastasize to local lymph nodes. This is Kaposi's. It's a classical appearance. When you see this in a man now, you have to assume he's not only HIV positive, but full-blown AIDS. Another thing I might want to point out is that for some reason that the AIDS patients with the homosexual backgrounds are more likely to produce KS than AIDS patients from, let's say, intravenous drug use. It's not a hardcore rule, but it's a generality that's been noted many, many times. Okay, and we said this before, but let's say it again because it's important, so we're going to say it in other words. Let's say that you have a tumor or a patch or a plaque or anything that looks like it might be vascular because it's red, or maybe it blanches, or now under the microscope you're looking at what look like spindly cells, which is pretty much common for any type of connective tissue neoplasm, whether it's benign or malignant, and you're saying, well, maybe there's some little slit-like spaces there too, and look, maybe that's an endothelial cell. So is this a connective tissue tumor in which there's just some blood vessels growing, or is perhaps the majority of this a connective tissue tumor? Well, you don't know, because whereas you could swear in a stack of Bibles that maybe that cell is an endothelial cell, and that is, can you really say that all the rest of these are? Well, they may or may not. And how do you differentiate? Well, you do the factor VIII stain. There's another really good one called CD31, and remember, these are all immunochemical markers that stain for specific antigens on the tumor cells. So if this part of the tumor, which doesn't have the slit-like spaces, stains for factor VIII or CD31, then you can say the whole thing is a vascular tumor. So keep that in mind. I'm not going to go much into immunohistochemistry during this course. That's more the domain of pathologists and pathology residents and the kind of seminars that we have on Saturday rather than the regular medical student presentations. Let's go into the malignant ones now. The generic all-around term for a malignant tumor of blood vessel origin is called angiosarcoma. Now, once again, the more likely it is to be malignant, or the more malignant it is, the less likely it is to actually show nice, well-defined, endothelial-lined vascular spaces. So on the malignant ones, you might not think that they're even blood vessel origin. You might say, well, this is maybe a smooth muscle, or maybe this is fibroblasts or histiocytes or something like that. But the fact that it's malignant means you'll see all the general features of malignancy. You'll see atypia, you'll often see frequent mitoses. Sometimes they'll be bizarre. In other words, rather than the mitosis going off in two directions, you know, the North Pole and the South Pole, it's going off in 3 or 4 directions, or a multipolar or tripolar mitosis. And of course, it'll behave like any sarcoma, whether it's due to blood vessels or connective tissue or not. It'll metastasize early to the lungs. And I want to tell you, I've known some people that have had sarcomas, and the very, very unfortunate situation is they often think they just have a cold, and then this cold doesn't go away. They're coughing more and more. It doesn't get better, so after a few weeks they go to the doctor and they do a chest x-ray and they say little nodules in the lungs, and they send them to CT and they have it in the liver. This is very often the way any sarcoma presents, not just the angiosarcoma. I got another little asterisk after the word hemangiopericytoma, because it's definitely malignant, but the name doesn't sound malignant, does it? We see the hemangio, that sounds benign enough. And pericytes, we know that pericytes are certain kinds of cells, but a hemangiopericytoma is a malignant tumor, and it can metastasize. It can behave just as badly as the angiosarcoma. And once again, I'm not going to show you a lot of different examples because it's also a heterogeneous group of tumors, and they often arise in the retroperitoneum. It's like the majority of liposarcomas also arise in the retroperitoneum. Okay, we're all done with the discussion on blood vessel tumors. It wouldn't be fair if we didn't have a couple, 3 or 4 more PowerPoints that go into some topics that I think everybody should be aware of with regard to blood vessels, because a lot of the blood vessels that people get now are surgically intervened. They're vascular interventions. People have angioplasties. People have artificial blood vessels put in called stents. People have grafts, either from their own blood vessels somewhere else in the body or synthetic grafts like Teflon. So it wouldn't be fair if we did say a few general closing words about angioplasties, stents, and grafts. Now you may know people that have had angioplasties, and if you know somebody that has an angioplasty, most likely they've had more than one, and also very, very likely it's been at the same place. Because angioplasties, whereas they can provide really nice release because you're putting a balloon inside of a blood vessel that's plaqued, and you're hearing the little crackling sound when you expand that, and you're giving a lot of extra blood. And of course, following that, there may be some dissection of hemorrhage because you're traumatizing a plaque. And initially there's dilatation, but the hard facts is that angioplasties are not expected to last forever. And if you look at the hardcore statistics, they generally restenose again in less than a year. I know a lot of the cardiologists and radiologists and heart surgeons, they don't want to admit that, but these are the facts from the literature. So angioplasties are very, very good temporarily. A successful angioplasty is diagnosed by your ear, usually, because you hear the crackling of the plaque as you expand the blood vessel. Now, what about stents? Stents are better than angioplasties because you're not just expanding the artery and hearing the crack and then taking the thing out. You're putting in a stent, usually a wire mesh sort of substance, and it's being expanded, and it stays expanded. And theoretically, you're increasing that lumen. And of course, the big tendency now is to put drugs onto the surface of this mesh. Long-acting drugs that will very often prevent further thrombosis, prevent spasm, and delay restenosis. So generally, the stent lasts longer than the angioplasty. It's there forever. When you do an autopsy on somebody that has a stent, 20 years ago, it's still there. It may still be working too. And they're almost all metal as well. Now, what about grafts? The coronary bypass graft has had a phenomenally good influence overall on survival of people with MIs and severe atherosclerosis. Just in the USA alone, there's about 500,000 cabbages done every year. I don't know if that number is increasing or decreasing, but if it is, it's probably related to money more than anything else, and perhaps more successful stent advancements. But it's still a huge, huge number. Now the question is, do you want to use a graft material like a saphenous vein, or do you want to use an internal thoracic, or we call internal mammillary artery? Well, if you do, or even if you use something that's synthetic, the hardcore statistics are, if you still have a good graft after 10 years with a saphenous vein, consider yourself lucky. Consider yourself even luckier if they use the internal mammillary artery, because those things usually have about a 90% patency rate after 10 years. And of course, not to say this because I've already said it 100 times one way or another, is that the general process of atherosclerosis can go on in the graft even if it wasn't there before. So endothelial, smooth muscle migration, all these little things we talked about in the pathogenesis of atherosclerosis are key factors for the success of that graft. And guess what? That was PowerPoint number 119. I feel real good. We're completely done with the chapter. I like to follow up the chapters with labs immediately, rather than 6 weeks later. So let's look at the clock here. The clock says 9:48. That's almost at the hour. So here's what we'll do. This is a good time to take our mid-break, and what we'll do after the break is go on to the lab. And I have about 15 cases here for lab. So what I'm going to do now is something you can't see. I'm just looking at your questions here and see if there's anything that I want to comment about, some of which I might know, some of which I might not know. Somebody used the term Kasabach-Merritt syndrome. You know, I'm sorry, but I just have never heard of that. So if that person would like to expand on it a little bit, that would be nice. Otherwise, I'll Google it and I'll pretend like I knew it all along. Somebody asked a very, very good question. If the vascular tumor is rather undifferentiated, would it still produce factor VIII? And the answer is yes. It might not produce factor VIII as strongly as a well-differentiated vascular tumor, whether it's benign or malignant, but it'll still produce it. In fact, that's the whole rationale, is that even if you can't identify endothelial cells because of their usual appearance, it will still be factor VIII or CD31 positive. So those are the two questions. We are now officially at the 9:50 mark, so we'll take our 10 or 12 minute break. Go get yourself a cup of coffee, recaffeinate yourself. I'll go down to the men's room downstairs and see you in 10 minutes. And this is a good song to start off our break with, by Mary J. Blige.
Neither one of us knew why. We didn't build nothing overnight, 'cause a love like this takes some time. People swore it off as a phase, said we can't see that. Now from top to bottom, they see that we did that. Yes, it's so true that, yes, we've been through it. Yes, we got rich. Yes, see baby, we've been too strong for too long. And I can't be without you, baby. And I'll be waiting up until you get home, 'cause I can't sleep without you, baby. Anybody who's ever loved you knows just what I feel. Too hard to fake it, nothing can replace it. Call the radio if you just can't be without you, baby. Yeah. I got a question for you, we already know the answer. Still I wanna ask you, will you lie? No. Make me cry? No. Behind my back and then try cover it up. Well, neither would I, baby. My love is only up and up. Yes, I'll be faithful. Yes, I'm for real. Yes, and without you, always know the deal. We've been too strong for too long, and I can't be without you, baby. And I'll be waiting up until you get home, 'cause I can't sleep without you, baby. If anybody who's just what I feel, too hard to fake it, nothing can replace it. Call the radio if you just can't be without you, baby. Yeah. See, this is real talk, come on, always stay. No matter what, good or bad, it can bend, right or wrong, all day, every day. Hey, now if you're down on love, or don't believe this ain't for you, no, this ain't for you. And if you got it deep in your heart, and deep down you know that it's true. Come on. Well, let me see you put your hands up. Hands up. Tell your lady she's the one. Tell your lady she's the one. Oh, put your hands up. Hands up, baby. Let her know we got your love. Look around in the eyes and tell them we've been too strong for too long. And I can't be without you, baby. I'll be waiting up until you get home, 'cause I can't be
give. So bring your good times and your laughter too. We gon' celebrate your party with you. Come on now. Celebration. Let's all celebrate and have a good time. Celebration. We gon' celebrate and have a good time. It's time to come together. It's up to you. What's your pleasure? Everyone around the world, come on! It's a celebration. Celebrate good times, come on! It's a celebration. Celebrate good times, come on! Let's celebrate. There's a party going on right here. A dedication will last throughout the year. So bring your good times and your laughter too. We gon' celebrate and party with you. Come on now. Celebration. Let's all celebrate and have a good time. Yeah, yeah. Celebration. We gon' celebrate and have a good time. It's time to come together. It's up to you. What's your pleasure? Everyone around the world, come on! It's a celebration. It's a celebration. Celebrate good times, come on! Let's celebrate. Come on now. Celebrate good times, come on! Let's celebrate. We're gonna have a good time tonight. Let's celebrate. It's alright. We're gonna have a good time tonight. Let's celebrate. It's alright. Baby. We're gonna have a good time tonight. Let's celebrate. It's alright. We're gonna have a good time tonight. Let's celebrate. It's alright. Celebrate good times, come on! Celebrate good times, come on! It's a celebration. Celebrate good times, come on! Come on and celebrate tonight. 'Cause everything's gonna be alright. Let's celebrate. Celebrate good times, come on!
Somewhere out
There,
beneath the pale sky, someone's thinking of me and loving me tonight.
that we'll find one another in that big somewhere out there. And even though I know how very far apart we are, it helps to think we might be wishing on the same bright star.
And when the night wind starts to sing a lonesome lullaby, it helps to think we're sleeping underneath the same big sky. Somewhere out there, if love can see us through, then we'll be together somewhere out there, out where dreams come true.
And even though I know how very far apart we are, it helps to think we might be wishing on the same bright star.
And when the night wind starts to sing a lonesome lullaby, it helps to think we're sleeping underneath the same big sky. Somewhere out there, if love can see us through, then we'll be together somewhere out there, out where dreams come true.
Wow. It's really kind of hard to get back into the swing after a song like that. Very, very powerful. I think I have one that's more powerful at the end, however. By this stage, you may be wondering who this, as somebody described it, beautiful, sweet young lady is. Her name is Rosa, and she's one of my students, and she's in the Caribbean. And I'm going to tell you a story about Rosa at the very end when I play our biggest, most beautiful song. That's going to blow you away. And until then, I want to tell you one more thing. We're finished with chapter 11. We're done. We're done with that stinking old lecture part, and now we're going to have fun, and we're going to go to lab. We took a survey last year, and we asked the students, what do you enjoy more, lecture or lab? And they all say, lab, 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 lab. And they say, well, what do you think is more important for passing your boards? And they go, yeah, lecture. So this is the part of the time that I have the most fun with. Part of it is because I'm in my element or my habitat of looking through the microscope and showing people, which I did my whole life, even before I went into teaching. And it's really, really fun. This is our microscopy session. And remember, for those of you who enjoy or perhaps don't have the time for the lab, all of the lab sessions on all 500 of the cases, they're on YouTube. They're also can be downloaded in their original high-resolution form from medicalschoolpathology.com. And they're also on GoPath as well as streaming. So these are things that are all for your convenience, because when we teach medical school here, we're not teaching at our convenience, we're teaching at your convenience. And that's why we know that over 90% of you will be watching the movies rather than coming to the live session, but I certainly appreciate the live session too. I want to deal with one question that was asked again during the first hour, because I was thinking about it more, and I want to just try to bring this into our general principles of pathology and tumors. Remember, we have said many times from day one that the more undifferentiated or the more malignant a tumor is, the less likely it's going to look like the cells of origin. That's probably the main principle of tumor pathology. It's called the concept of differentiation. Now, somebody asked, could undifferentiated tumors also stain positive for the antigens? Like in this case, it was the factor VIII antigen we're talking about. And I said yes. And that's probably a correct answer. But remember, even way after your human eyeballs cannot recognize cells as coming from certain tissues of origin, the antigens within the cytoplasm or within the nucleus will still be there. And that's the beautiful about immunohistochemistry. I don't do much of it here because it's usually not a topic for students, but if you were to teach residents, everything now is IHC, or what we used to call immunoperoxidase or immunochemistry. Now they use the nice three-letter acronym IHC for immunohistochemistry for differentiating certain kinds of tumors. Let's go to lab. And if you remember, what we do in lab is we get up off our chairs here in the lecture hall and we take a nice walk down the hallway. Hey, don't forget your coat. And then we open up the door to the lab, and we throw our coats on the lab chairs, and then we get out our keys or our combinations. We go to our lockers. We see if our microscopes are still there, if somebody stole them. We see if our glass slides are still there or if they're broke. You plug in the microscope. You take 20 minutes to try to tune it up. And then you say, oops, the light bulb is burned out. So you go into the store and you buy a light bulb. And you come back and then you focus it, and then you look at slides and you say, what the hell is this? So then you say, well, maybe our lab instructor knows the answer. So after 20 minutes, you're allowed to talk to the lab instructor because he's done talking to all the cute girls. And you say, what is this? And then he takes 20 minutes to focus his eyeballs, because his eyeballs are different from yours. And he looks at it and he goes, I don't know. So at least we have the advantage of all looking at everything together with somebody, me, who's seen these things a lot of times, and I generally know what I'm talking about. And sometimes, even when I don't, I'll pretend like I do, but I try to keep that to a minimum. So let's go to our first case. We have 12 cases today. Very often we have to jettison cases because we're running out of time, but I think we'll have time to talk about all 12 of these cases today. They relate very, very, very much to the topics we just talked about. Some of them we've actually seen before, because on some of these things I've captured off of the microscope and putting onto the PowerPoint. So a good place to start, and once again it's alphabetical. If you go to Rock Lab, you see the vascular stuff is alphabetical. So A is at the top of the list, and I guess the word adrenal begins with A. So we go to our slide in our slide box, K202, which is over here. You can see the thumbnail, and that's our first case. You already know where it is because it's alphabetical, so you know that's an adrenal. And let's put it under the microscope, and I know exactly when it's going to be in focus for your eyeballs. It's going to be in focus for your eyeballs right now. And sure enough, it looks like an adrenal gland. You can see some fat in the capsule. You could see the capsule surrounding the various layers of the adrenal. And if you could see, even from this low power, the most superficial layers of the adrenal look like little glomeruli, don't they? So that would be the zona glomerulosa. Yeah, they look like little glomeruli. And then as you go deeper down, they go into straight lines like fascicles. So that's the zona fasciculata. So I went to the G for glomerulosa, to the F for fasciculata, And now we'll drag down to another area here that isn't really straight lines, but it's more like a reticulated pattern. So you call that reticularis. And so you went from G to F to R. And isn't that funny, because it's sitting right on top of the kidney where you have glomerular filtration rate. So these are the three layers of the adrenal. The glomerulosa has the mineralocorticoids, the long fascicles, which is usually the majority of the thickness of the cortex, which is usually about 1 millimeter in real life, is a fasciculata, and that's this cortisol, or the glucocorticoids. And then the reticularis is the reticular part that has the sex hormones, the androgen-like compounds. So you went from GFR, you went from salt to sugar to sex. And you know, one of the students actually made a comment on one of my YouTube things, and he goes, well, you know, that sounds like the deeper you go, the sweeter it gets. Okay, well, let's take a look at this adrenal. You know, these are some kind of artifact because they're not staining right, and I don't know, maybe this is something that was actually burned out once with a very high intensity light, but the adrenal doesn't look too bad. So you say, okay, well, Dr. Minarsik screwed up. He showed us a normal adrenal. And my only defense is that you have to look at everything, and sometimes you have to be boring, and you have to look around. And you know, when you get to this part of the adrenal, where you have large, wide open vascular spaces surrounded by smooth muscle, and sometimes maybe ganglion-looking cells, you know that that's the adrenal medulla. So you say, well, thank you very much for the nice normal histology thing, but what the hell are we doing here? Take a look at some of these blood vessels, like here, and here, and here, that are in the periadrenal fatty pericapsular connective tissue. And here. So this looks like a nice big one. Let's take a look at it. So I'm going to zoom in on the northeast over here by drawing my little box. And I'm going to start to ask you some questions. And the first question is, what the hell is this? Well, you know that's the easy part. You know it's a blood vessel. You could see it also has kind of a thick wall. So it's an artery, which somebody pointed out. But what do you see surrounding the artery and even towards the intima in many respects? You see inflammatory cells. Yeah, it's an artery, all right. Look, you could probably even see some fragments of adrenal tissue here, like there, way in the extreme northwest. But you could see a arterial wall that looks a lot redder and even more granular than the normal smooth muscle. So would you like to call that fibrinoid necrosis? Absolutely. This is a really good example. You have a blood vessel, an artery, a relatively small artery, that has inflammatory cells chiefly on the outside of the vessel, so periarterial, but you can also see that these inflammatory cells also involve the media, and they also involve the intima. So this is a panarteritis, right? All three layers. But it's also a periarteritis because most of the inflammation is on the adventitial and outer muscular layers. So would somebody like to venture diagnosis? We said it's a periarteritis. What if I was to tell you that grossly this artery might have a nodular appearance? You know, because the artery is being affected only in little segmental fashions. We have a periarteritis, and it's nodular. And of course, I already gave you the diagnosis. It's periarteritis nodosa. If you wanted to call this polyarteritis nodosa, because we saw that other arteries are involved as well, would it be the same term? And of course the answer is yes. Okay, so What else do I want to say about this? Oh yeah, here's what I wanted to say. This is a classical example of a systemic autoimmune disease, polyarteritis nodosa. We talked about it when we were talking about the immune diseases. And isn't it kind of unusual is that when we told you that there's basically two types of arterial diseases, there's atherosclerosis, number one, and number two, everything else. Isn't it kind of unusual that with atherosclerosis, the primary process is intimal and subintimal and towards the lumen of the vessel, but with the arteritis, the primary destructive process is peri, or around the artery. And yeah, I agree that there's some stuff here on the intima as well. So could you keep that as a general thing in mind, is that atherosclerosis starts out in the intima and quite frankly in the endothelium originally, but the arteritis very often are surrounding the artery. The worst part of it is around the artery. So this is polyarteritis nodosa. Okay, now this is the number one question. Let's say that I told you that this patient also happens to have a diagnosis of either lupus or rheumatoid arthritis. Would you then want to say that maybe this vasculitis is part of the lupus, or the vasculitis is part of the rheumatoid arthritis, rather than go and diagnose a whole different new autoimmune disease? And of course everybody is saying yes, 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 yes. So good, you got everything right so far. Now here's the real trick question now. Is there anything about the pattern of inflammation in this artery that would differentiate it between an arteritis secondary to rheumatoid arthritis or a polyarteritis nodosa? In other words, if I showed this to, the last 10 pathologists that won Nobel Prizes, and I said, okay, is this part of rheumatoid or is this periarteritis nodosa? Tell us if you could tell the difference. And in all honesty, they'd have to say no. So yes, you got that question correct too. And we could look at another couple of arteries pretty briefly as well if you want to. We saw the one up here in the northwest, but here let's take a look at the one down here in Texas. And I think you can see they all look about the same. It's basically a polyarteritis, but there is some trans or pan arterial wall involvement too. So there's another one. And you want to see another one? Oh, let's take some of these smaller ones out here. They all look pretty much the same. And remember, we're dealing with more than one artery here, aren't we? So by definition, that makes it polyarteritis. Now, could there also be arteries supplying the brain or small bowel or liver that are also inflamed with this disease? If it's polyarteritis? And of course the answer is yes. You got that one right too. Now, I want to show you something really cool, because I've been talking about fibrinoid necrosis, and you've probably been saying, oh, Minarsik doesn't know what he's talking about. He talks about fibrinoid necrosis, amyloid, hyaline. Gee, it all looks like red junky stuff to me. How does he know? Well, here, take a look at this relatively normal small artery here. Do you see how it has a sort of a uniform pink smooth display of smooth muscle cytoplasm? Now take a look at this artery here. Do you see how it's more red and more granular and less smooth? That is fibrinoid necrosis. So a good question would be, what is the usual pattern of necrosis in arteritis? The answer is fibrinoid necrosis. What if I said, what is the usual pattern of necrosis in brain injury? Well, you'd probably say liquefactive necrosis. What if I said, what's the usual pattern of necrosis in large TB granulomas? You'd probably say caseous necrosis. These are just conventional terms, and they're not meant to, exclude anything. So you all got the questions right. So that means we can move on to the next case. And the next case will be It's called AUT03, so I guess we have to go to the A's. And looks like the A's are over here. AUT03. Here it is. See, there's the thumbnail, folks. Anybody want to guess what that is already? Just from looking at the thumbnail? I'll give you an A for the class if you do, if you get it. And you can see it looks like the arches at McDonald's. Well, maybe you get a B. Yeah, you can tell it's an artery. I'll give you half credit for that. Now, can I ask you another question? Because as of right now, you're all looking at it. And yeah, I agree, it looks like a blood vessel wall. And can I ask, what kind of blood vessel you think this is? You think this is an arterial, a muscular artery, or a really, really big artery? You know, is it an aorta? Anybody want to take a guess? No, nobody wants to take a guess. Well, it's awfully thick, that's for sure. And somebody said elastic. Well, that's really a very astute observation, because I'm going to blow up the middle of this wall. And remember, this whole thing is nothing but blood vessel wall. Now, here's the question. Do you see these little white squiggly fibers? I know they look white. Like here, this is a good one right here. You see this whitish squiggly line? You see this whitish squiggly line? You see this whitish squiggly line, and this one, and this one, and this one, and this one, all the way through. What are these white squiggly lines? Remember, this is just the H&E stain. These are elastic fibers, absolutely. And what if I told you that if you did an elastin stain, this perfectly white, pinkish, squiggly line would now be intensely black? Then it would prove it was an elastic fiber. But don't think that you can only see elastic fibers with an elastic stain. When you look at a normal aorta with just regular H&E, you can see they're all over the place. Okay, so now we know that there's a lot of elastic in the aorta. Well, big deal. Everybody knew that anyway. What if it was what we call an elastic artery, like an innominate, or the origin of a carotid or something like that? Would you expect to see elastin fibers all the way throughout the artery, or perhaps just towards the middle portions? They certainly have more than just the internal elastic lamina. They'd have a lot of elastic fibers. Maybe not as much as in the aorta, however. So we're back down to our regular pictures. Now, here's the next question. We said that every artery has 3 layers: intima, media, and adventitia. Well, when you see all this connective tissue and blood vessels and fat, you know this is adventitia. So it means this is the media, right? And now the other side has to be the intima. So if we're calling this part here the intima, then we have to prove it by zooming in and maybe finding a few endothelial cells. Look, there's an endothelial cell. Some of these could be too, but when you see a nice little flat cell like that right on the surface, you know that's an endothelial cell. Now, can I ask another question? What is this white, pink, squiggly line here, and here, and here, and here? These are all elastic fibers again. No, somebody said vasa vasorum. Remember, vasa vasorum, if you see a blood vessel within a blood vessel, by definition that's a vasa vasorum. But as you know, most of the vasa vasorums will be towards the adventitial aspect. Because the reason why you need the outside of the artery with blood vessels is because it's not right up against the blood. So the further you are towards the outside of an artery, and here certainly in the adventitia you have a lot of vasa vasorum, and sometimes they protrude down here, like here, into the media as well. But as you go towards the middle of the media and then towards the intima, they almost disappear, because you don't need blood vessels all the way down here. You got blood right up here against your intima. So let's just kind of move along the intima. And are you thinking, well, maybe this intima looks just a little bit whiter and foamier than normal, like, and you're thinking, could some of these things maybe be foamy macrophages? I don't know. That's your thing that you're wondering about. But let's go back to the big picture now and look at the other side of the aorta. Well, once again, here's adventitia, here's media, but look, now you have sort of like a little whitish, foamy substance on the intima. And I'm going to blow it up for you up here in Minnesota. And I want to ask you, what's all this white stuff? Yeah, it's a plaque. Ah ha ha ha. Somebody said plaque, and that's up for discussion now. Because it's only a plaque if you could put on a blindfold and feel it. If the only evidence you had for it is that it looked yellow, would you call it a plaque or would you call it a fatty streak? Well, the reason why I'm asking you that is because this particular slide was labeled as fatty streak. However, in all honesty, if you really think that you could feel this little bump and it is not just yellow but you could feel it, then it would deserve to be called a plaque rather than a streak. Otherwise, if it's just very, very subtle, you know, like this, and maybe you see some foamy cells, like here, for example, you might tend to call it a plaque. But if you can really feel it, if your fingers are gooder than mine, and you could call it a plaque. Otherwise, this was labeled as fatty streak, but that's debatable, isn't it? Now, let's zoom into this area here, the part that we're talking about. And I want to ask you one last question. What are 90% of these cells that you see here? Fat is correct. Anybody want to be more specific? Foam cells. Anybody want to be even more specific than that? How about foamy macrophages? Okay, so you know that the foam inside these macrophages are cholesterol and cholesterol esters. Now let me ask you this. If this foam wasn't just intracytoplasmic, but it was big enough to cause actual crystals outside the cells, what would you call those little spaces then, those little needle-shaped spaces? You call them cholesterol clefts, wouldn't you? Except you don't really see any good cholesterol clefts here. It's mostly foam cells. So what comes first, the foam cell or the cholesterol cleft? And of course the foam cell comes first. Okay, good. I'm glad this was not a chicken versus egg question, because I never get that one right. Let's go on to the next case, and this is going to be number 039. So here's O and here's 39, and take a look at it. It looks like another aorta, doesn't it? And it looks like a double aorta again, and you can already tell that probably on this side of the aorta it looks like it's maybe fat, so that's probably going to be the adventitia. And it looks like there's some adventitia here, but look, looks like there's also some thickening on the other side, which means you know what this is also going to show. Bingo. This is connective tissue. There's even some nerves. Remember, the aorta has nerves on it, the sympathetic, chiefly sympathetic fibers. Here's some fat, here's some veins, here's some fibroblasts, and here. So this is the endothelial end of the artery, which is the intima, and here's the adventitia, and the dense pink stuff is basically the media. Now, can I ask another question? How do you know this is an aorta? Again, here, I'll help answer that question by giving you a full thickness slice. So the question is, how do you know this is an aorta? Well, it's because, once again, these really subtle pink squiggly things extend the whole length of the media. The aorta is the only elastic artery in which these elastic fibers go all the way from the intima to the adventitia. And if you don't believe these are elastic fibers, then you do the elastic stain. Okay, So, if we said that this was the intimal end and this was the adventitial end, can I ask you one thing? What are these little slit-like spaces over here? Here, and here, and here, and all over the place. Yeah, these are the cholesterol clefts. And the reason why you just have to call them clefts is, you know, cholesterol is a fat, and like every other fat in the body, it looks yellow grossly, but it also gets dissolved when the tissue is processed. So if we didn't have xylene in the preparation here, you'd maybe actually see the actual crystals. But the problem is, it might cut in a very jagged way. So that's why we have to make sure all the crystalline, hard, gritty material is out before we can make nice thin sections. So this may be kind of boring, but you know, all you see here is fibrous tissue, cholesterol clefts, maybe some foam cells. You may and probably won't see a good dividing line between the intima and the media, because, you know, it's not fine. You know, fibroblasts have migrated, it's very disrupted, and this is probably about as good as a separation as you'll ever see. And whereas most of the things you're seeing here are clefts, I bet you if we go a little bit deeper, you can see some residual foam cells too. And if I'm wrong, I'm wrong, but I think that these are probably foam cells. Aha! We just got another substance here which we were not expecting to find. What is this very, very, very dark blue gritty stuff? And yeah, you already know that. That's calcium. So the cholesterol clefts are crystals, but they dissolve out, but the calcium doesn't. In fact, if this was really calcified, chances are when you cut through it at autopsy, you would hear it. It would be crunchy, just like when you do a angioplasty. You hear the crunchiness of the calcium breaking up. Otherwise, probably most of these cells are fibroblasts. And you know, I wouldn't be surprised if this could be a foamy macrophage here, and maybe one here, maybe a couple over here. So this is another more advanced lesion than we saw before, because the predominant calcium here now is in cholesterol clefts. It's not in foamy macrophages. And cholesterol clefts are more likely to be in plaques than in streaks, because as you progress from a fatty streak to a plaque, you generally get more cholesterol, so you go from just the foamy macrophages. Somebody said, could this be a vasa vasorum? Okay, well, what is a vasa vasorum? A vasa vasorum is a blood vessel within a blood vessel. But remember one thing. The atherosclerotic process is an inflammatory process, and normally you have blood vessels growing within this inflammatory process. I would not call this a vasa vasorum. If there were blood vessels in here, and there may very well be, you would call those blood vessels as part of the reaction of inflammatory plaque. Technically speaking, vasa vasorum are blood vessels which grow mostly towards the other end of the artery, and they supply and feed the outer portions of the media and extensively throughout the adventitia as well. So here, I'm going to show you some nice vasa vasorum here if I can. Oh, there's one. There's one. That's definitely one. That's definitely one. And as you go more towards the media, they get a little bit more rare. And sometimes you could see them actually in here. And of course, the adventitia is very, very rich in blood vessels. There's a major, major vein alongside that aorta over there. And I bet you there's another vein. And looks like that's an artery. Oh, that's definitely an artery, because look at the thickness of the muscle. And sometimes when you see like a couple arteries together, don't think they're different arteries. It's probably the same artery that's been cut in different planes. And last but not least, I wouldn't be fair to you if I didn't find a nice nerve. So please stop me when you see the nerve. Bingo. That should be a complete instant knee-jerk reflex of a nerve. Okay? and it's myelinated because most of the nuclei you see there are Schwann cells. Now let me ask you this. Is this most likely to be a sympathetic nerve? Yes. Okay, correct answer. Let's go down to the next case now. You're doing so good today. This will be 4790 is the next one. If it seems like we're spending a lot of time on atherosclerosis, I want to remind you that's going to be the disease that you spend most of your time treating. So 4790 looks like it has to be somewhere around here. 4790. Here you go. It doesn't have a thumbnail for some reason, but I know it works because I tested it twice yesterday. And you see it right now. And it's a good thing there wasn't a thumbnail because I think that this pretty much gives it away. So let me ask you two questions about this one slide here. Question number one, what's the disease? Just answer it right away. Question number two, what is superimposed onto this disease? Thrombosis and atherosclerosis. Absolutely right. That's so important to remember because heart attacks don't occur from atherosclerosis, or any acute coronary syndrome does not occur just through atherosclerosis. It's atherosclerosis plus there's been enough intimal damage to evoke a thrombosis as well. So the majority of this compromise of this lumen is actually with a thrombus rather than atherosclerosis. Now I must admit that when you get to an area like this, it's hard to say where the atherosclerosis ends and where the thrombosis begins. So most of this really red stuff here is blood clots rather than atherosclerotic plaque. Okay, second question is this. What percent of the normal diameter of this blood vessel is occluded or compromised by this double disease process? And I'm seeing all the answers in the high. I'm seeing 90, 95, 90, greater than 90. And that's what I would say too. Not 100, but probably at least 90, I would think. And okay, pretty good. Here's some fat within a plaque. Most of the thickness of this thing is plaque, so this lighter areas probably will see foamy cells. I think from even this power, you can see some cholesterol clefts. Maybe we'll see some calcium microscopically. In fact, hell, let's take a look right now. Yeah, here's cholesterol clefts. Here's foamy stuff. Here's more clefts. Here's part of the thrombus. I don't really see any calcium here, but I bet you if I scouted around a little bit faster than you could catch up with me, we'd probably find a little bit of calcium here and there. But up until now, I don't see any calcium. Okay, now let me ask you a key question here. What do you think all of these, or most of these, white spaces are within this thrombus? Somebody said fat, somebody said necrosis, somebody said blood vessels. Here, let's make this easy. You see this white space here? I'm going to blow it up really big. There you go. There's a white space. There's a white space. This white space happens to be lined by flat cells. So what kind of structure is this? This is a blood vessel. Okay, so you have blood vessel inside of a severely damaged artery. It could be due to three reasons. Number one, it could be normal vasa vasorum, which you don't usually see in the intima. Anyway, number two, it could be organizing or neovascular changes within this thrombosis. Or number three, it could be recanalization. That would be a great board question. In fact, I'm asking it right now. Aha! Somebody got the right answer. It's organization. Well, it wouldn't be a vasa vasorum because it's not towards the outside of the vessel. And there's so many other vessels in here, I would not call this recanalization. However, let's go to that little slit-like space. And we're going to do that right now. And the little slit-like space was over here. That was what we called the remnant, or the 10% remnant. And let's blow it up a little bit. This is probably the remnant of the lumen. Well, on this side it looks like it's just part of the thrombus, but it's no more likely, if you were to look throughout here, you might see endothelial cells, because that's all that's left for the blood to flow through. What if there was another sizable endothelial line space somewhere at the edge of this thrombus? What would you probably call that? Yes, that would be called recanalization. Now, I would not call this recanalization because it looks like it's just the remnant of the lumen. And certainly all these blood vessels here, you would not call recanalization. They're just organizing changes within the thrombus. So, here's the question. Is this thrombus recent, like within 24 hours? Or is it old, like maybe months old? Or is it in that intermediate stage that we call organizing? Yeah, it's organizing, isn't it? If it was recent, it would be almost all fibrin, wouldn't it? If it was remote or old, it would be almost all fibrous tissue. But when you see blood vessels, it's in that intermediate stage called organizing. Now, as this thrombus ages, you get more fibroblasts and less blood vessels. And that means you're going from the time period of approximately days to either weeks or months or years. So this is a pretty severely involved artery, isn't it? Okay, last question. We're going to do something very clinical right now because, you know, I know you've been primed to learn that pathology should be clinical, clinical, clinical. That means that most of the people that teach pathology in the world don't know a damn thing about pathology because they're not pathologists. But I want to ask you a final question. Do you think that if this artery happened to be the left anterior descending or the circumflex, do you think that patient would be symptomatic right now? Maybe with the infarct, maybe with chest pain. Okay, good. Now, here's the final question. If this artery was the left main coronary artery, do you think this patient would be alive right now? Thank you. You got that's the correct answer. Okay, in fact, we are already leading into the topic on heart now, aren't we? Okay, let's do another case. We did very well on this one. Let's have some more fun now and go to 3627. And this is going to be a great case. And I bet you none of you will get it. But we'll see. Maybe there'll be some wise guys out there. 3627 looks like it's over here. There you go. See that? It's highlighted. Anybody want to give me a diagnosis off of the thumbnail yet? Of course not. Not unless you cheated and looked at this in lab. Fat tissue. That's about as good as it can get. And yes, there is fat. There's fat here, there's fat here, there's fat here. There's a lot of fat. But we're talking about the stuff here in the middle of the fat. For example, do you think these three things out here are arteries? Yeah, they are. And they look like they're sort of normal arteries. They certainly have thick walls, and they certainly have wide open lumens, and it doesn't look like they have any plaque. In fact, could this most likely be the same artery that's just cut three different ways? Or do you think this is three completely separate arteries? There's probably the same artery. You remember in histology, the tissue squiggles, and it's in 3 dimensions. But what about this artery here? And what about this artery here? And what about this artery here? And what about this artery here? So here's the first easy question. Let's take the artery up here in the northeast. what percentage of its lumen is occluded, or obliterated, or stenosed, or compromised? And I'm seeing high numbers, anywhere from 40 to about 70, and that's probably what I would say too. Now, what about this artery here in the southeast? What percentage of its lumen is obliterated? Oh, I'm seeing anywhere from 99s to 100s over here. I would say it's virtually completely obliterated. What about this one over here? What percentage are you going to give me over here? 95 or something? Who knows? Yeah, sounds good. How about 96.37214? Would you agree with that? Let's open up and explode one of these big arteries now, like this one here, the big one that looks like it's obliterated. And let me ask you a question. Do you think this is atherosclerosis? Look at that beautiful internal elastic lamina, that squiggly little mountainous highway that goes all the way around the lumen, which is virtually obliterated. And there's no plaque, there's no calcium, there's no foamy macrophages, there's no cholesterol clefts, there's no fibrosis. It looks like it's inflamed. It looks like it's organizing inflammatory tissue. So number one, it looks obliterated, and number two, because of it's inflamed, you might also use the word angiitis or vasculitis. And it looks like it's thrombosed, not by blood clot, not by plaque, but by this inflammatory process within the intima. So let's see, what do we have here? We have thrombosis, we have angiitis, we have obliteration. What if I was to invent a disease called obliterated thrombosis angiitis? Hey, there is a disease. It's called thromboangiitis obliterans. Do you remember what the other name for this disease is? We talked about it a little bit the other day. Yeah, it's Berger's disease. This is classical Berger's diseases. Now, the one thing I forgot to tell you about Berger's disease, and I remember now, is, you know, I'm an old guy. I'm going to be 65 in a couple months. But if you were to ask me what is the most memorable picture I ever saw in medical school, and it was a picture of a guy with thromboangiitis obliterans. He smoked. He smoked so bad that he lost his leg, and he kept on smoking. So guess what? He lost his other leg. He kept on smoking, so he lost his arm. He kept on smoking, so he lost his other arm. And the picture that I saw was basically a guy without arms or legs laying down in a hospital bed, and guess what he had in his mouth? It was the most unbelievable picture I've ever seen in my life. Yeah, he had a cigarette. And at least you could see that this is not really atherosclerosis. But another thing is, if I was to tell you that this is the most beautiful example of a perfectly intact internal elastic lamina, you don't even need an elastic stain for it, you would believe me. And that's basically what's going on here. Okay, so much for Berger's disease. Let's go to, by the way, the main treatment for Berger's disease is to quit smoking, as you might guess, but cigarette smoke damages blood vessels. That's a well-known fact. But in some people, their endotheliums are extremely sensitive to cigarette smoke, some genetic reason, and those are the people, you know, that lose their arms and legs from smoking. Let's go to 4066. We're about halfway done. 4066. Here we go. See it? Here's the thumbnail. Somebody want to give me a diagnosis from the thumbnail? Somebody want to tell me what these big things are at the top of the thumbnail? Anybody want to take a wild stab at it? Take a shot at the title? Somebody said thrombi, and somebody said brain. And guess what? You're both right. Probably on very, very quick recognition, the tissue on the bottom, you know, in the southern hemisphere here, looks like brain. We could do a quick reality check and say, yeah, there's a lot of oligodendrocytes, there's a lot of blood vessels. I don't see too many neurons, but it looks like classical brain. That's the thing you say is a knee-jerk reflex. Okay, so we know this is brain tissue. Big deal. Let's not go into it anymore. Now, it looks like compressing this big brain tissue are large spaces, look like with fairly thick walls, and there's a lot of blood clot or blood in these large spaces. So somebody's already given me the correct diagnosis. AVM, arteriovenous malformation. You notice how they can have kind of a mass effect? This is AVM of the brain. What if somebody said to me, well, could this be a hemangioma of the brain rather than an AVM? And I would say, you know what? It's probably going to be very, very hard to differentiate that microscopically. But what if we were to zoom in on the blood vessels over here, the wall of the blood vessel, and you would say, well, you know, this doesn't really look like an artery because it has such a wide open lumen. But nevertheless, the wall of it is very, very thick, probably about as thick as an inferior vena cava. So why would a vein-like structure decide to get a very, very thick wall? Because of increased pressure. And the increased pressure is coming from the fact that the arterial blood in this malformation is mixing in with the venous blood. So the venous blood winds up having a thick wall. And let's say that the wall thickness can't keep up with the increased pressure. What do you think is going to happen? There's going to be hemorrhage within that brain. So the two ways AVMs of the brain can kill you, and I've gotten about 8 emails from my movie on AVM from people, and they say, you know, my son, my father, my sister died of this. And they died probably either because it was a large mass effect on a critically important part of the brain, or more likely the pressure of the venous part of the malformation couldn't keep up with the arterial and the wall ruptured and there's acute hemorrhage within the brain. So those are the two ways AVMs can kill you. So do we really want to say anything more about this? Yeah, let's take a quick picture again. And if you were to call this a hemangioma on a test, I wouldn't blame you. I might call it a hemangioma as well. But this one happened to be labeled AVM of the brain. Let's look at 4009 now, as long as we're doing such good progress here. 4009 looks like it's over here. There's the thumbnail, folks. Anybody want to guess at the diagnosis? Yeah, blood vessels. Do they look like they have all the uniform lumen or some? Yeah, okay, shit. I can't fool you. You all know this is atherosclerosis, but I'm going to show this slide anyway. It's certainly not an aorta. What if I were to tell you these were coronary artery sections? And look, in this one vessel, you have a relatively normal vessel on the southern side of the vessel, but on the northern side of the vessel, the wall was 3 or 4 times as thick as it should be, and it's all this foamy material. On this blood vessel, the eastern side looks pretty normal, but the western side has this big plaque. And do you see how this thing looks a little bit bluer than this? I bet you if we zoomed in on that, we'll find calcium there. And look, do you also see on this blood vessel, it's kind of normal on the bottom again, but the top part is about 8 times thicker than the normal part. This is all plaque again. And look at that red stuff is probably blood vessels, and I bet you those little slits are cholesterol clefts. So what do you want to go after now? Let's look at the normal part of the artery. That's a good place to start. These are coronary blood vessels. There you go. There's your intima. You probably can see internally elastic lamina. See that light squiggly thing? And then you see some nice smooth muscle layers. And then you see looser connective tissue. And then you kind of lead into this area here where you're getting to have a lot of thickening of the wall. and you're losing the integrity. You see, here's the internal elastic lamina. You're losing the integrity. You're seeing cholesterol crystals. You're seeing foam cells. And almost the entire thickness of this wall now is plaque. Look, this is all cholesterol crystals. And you see where it's starting to get a little bit bluer? Do you think if we were to look for calcium, we'd look in this bluer area? Do you think that's the nucleus of a foam cell, or you think that's a fleck of calcium? Well, to tell you the truth, I don't know myself. What about those little granules over there in the extreme northwest? What do you think that is? Those are little calcified microparticles, aren't they? These are all cholesterol crystals. And what we'll do now is we'll go to the one up here on the top that looks like it's quite a bit bluer than this foamier stuff. And I bet you, maybe I'm wrong because I didn't look at this part before, I'm betting you we'll see some calcium here too. Yeah, look at these are all calcium flecks. You see that? Here's cholesterol. Here's fibroblasts. Now, the one thing that is very often difficult to differentiate in the plaque is to whether some of these cells are migrated smooth muscle cells versus fibroblasts. But let's say, for example, we did a Masson trichrome stain and most of this pink stuff here remained pink. Then you would probably guess that most of these are smooth muscle cells. But let's say that the part over here was green. Then you say probably most of these cells are fibroblasts. And don't feel bad, because I could tell you, even like my really good pathologist friends that are, crackerjack pathologists, even on a good day, sometimes they can't tell whether an individual cell is a fibroblast or a smooth muscle cell, so don't feel bad. So instead, let's move on to the next case. And we have only 5 more cases left, and I see we only have 5 more minutes left. So guess what? We're going to have to narrow this down. Okay, guess what? I decided that we're going to take just one more case, and it's 39:45. You see, we have so much fun doing this, I lose track of time, and that's why I always have to abandon some cases at the end. There's 39:45 over there. I know you can all see it. What does it look like to you on the thumbnail? Yeah, it looks like a vessel. Would you say it's a vessel with a thick wall? Yeah. It's an irregularly thick wall? Yeah. So let's put it under the microscope. And I know you can all see it as of right now. So yeah, these are thick-walled blood vessels. But, can I ask you a question? I'll blow it up even more. Are there inflammatory cells on the outside and in the middle, and a little bit less likely towards the intima? So it's an arteritis, isn't it? Aha. Now, you see this area here where there's a lot of inflammatory cells? Let's zoom in on that. And that's exactly what I'm going to do. So yeah, there's a lot of inflammatory cells there. You got the answer before I even showed it. That's not fair. I'm going to flunk you guys, whoever you are. I don't even know who you are because I don't look at the names. But look at, these are multi-nucleated giant cells in areas of fairly well defined collections of inflammatory cells. These are giant cells, and it's an arteritis. So what do you think a good name for this would be? Giant cell arteritis. Haha, got the right answer. Which artery is giant cell arteritis most often diagnosed in? Temporal. Why is it mostly diagnosed in temporal? Because that's one artery that's not only very easy to biopsy, but it's an area that has an abundant amount of collateral circulation from other arteries as well. Even though giant cell arteritis may be involving intracranial arteries and ophthalmic arteries, and the patient is going blind, the only place you could see it, even grossly, is in the temporal artery. So there we go. Last question about this case is, if this patient with temporal or giant cell arteritis, now it's biopsy proven. if this patient also had an extremely high erythrocyte sedimentation rate, then what disease would you diagnose? It's not an easy question. It means you had to be listening careful the other day. Well, it's called polymyalgia rheumatica. So if you don't want to go to Google or Wiki and look at everything about the disease, just remember polymyalgia rheumatica, also like giant cell arteritis, an autoimmune disease, systemic autoimmune disease, has two things. Number one, it has giant cell arteritis, and number two, it has sky-high elevated erythrocyte sedimentation rates. We're done for the day. It's exactly 11 o'clock. I know you've been working hard, so I don't want to take you too much after the hour, and also I feel like I got to reward myself by quitting also. But I will take a look at the question box, and see if anybody wants to raise their hand about anything, because if I didn't give you the chance to speak, then you might as well just be watching the damn movies and not coming to the classes. So I'm going to look at our attendee list. I'm popping out the window. We still have a really large number of people still here. Nobody has their hands up, and that's okay. At least I gave you the chance. Now, we're going to quit. I want to tell you the story about this girl, Rosa. Rosa's father came over here from another country about 10 years ago, and he wanted to bring his family over. She was just a little girl then, okay? Well, it just so happens that when he came over, it happened to be on 9/11. So it took him 10 years or 8 years to get his family to be with him finally. And during those 8 years, Rosa Muradi's father waited patiently and loyally for his family. And when she told me that story, I practically fell over. And that's why I'm dedicating this class to her and her father with the most beautiful song I could think of right now by Juice Newton. See you in a couple of days, folks. Still in your eyes, I remember all the laughter and the tears we shared last night as we lie just two shadows in the light before the dawn. Sweetest thing I've ever known is loving you. And I have sweetest thing I've ever known is we're not children, we have both been done before. We have given and we have taken in life on, you buzzards.